A sympathectomy is a procedure to cut or block a sympathetic nerve. Sympathectomy Cervical. The physician makes a midlateral incision of the neck and dissects the tissues to locate the sympathetic chain. The ganglia are identified and resected. The incision is sutured in layers. Sympathectomy Cervicothoracic. The physician makes a thoracotomy and dissects the tissues to locate the sympathetic chain along the vertebral bodies. The wound is sutured in layers. Sympathectomy Thoracolumbar. The physician makes a lateral incision through the thoracic area to reach the sympathetic ganglia, which lie on the lateral border of the vertebral column. The physician determines at which level to remove the ganglia, and dissects to the vertebral bodies. The sympathetic plexus is located and resected. The wound is sutured in layers. Sympathectomy Lumber. The physician makes a lateral incision through the lumbar area to reach the sympathetic ganglia, which lie on the lateral border of the vertebral column. The physician determines at which level to remove the ganglia, and dissects to the vertebral bodies. The sympathetic plexus is located and resected. The wound is sutured in layers. Sympathectomy Digital arteries, each digit. Radial artery. Ulnar artery. Superficial palmar arch. The physician performs a digital sympathectomy using a microscope for visualization. The physician makes an incision along the digital artery in the medial and lateral aspects of the digit. The artery is identified and the adventitia is stripped from the blood vessel. Peripherally, the sympathetic nerves follow the arteries and lie in the adventitia layer. The incision is closed in layers. A corpectomy or vertebrectomy is a surgical procedure that involves removing all or part of the vertebral body, usually as a way to decompress the spinal cord and nerves. Vertebral corpectomy common method. The patient is placed in a lateral decubitus position and the muscle, fascia, ribs, and organs are incised or retracted. The dura may be incised. The physician makes a groove in the vertebral bodies above and below the crushed vertebra and removes the discs above and below. Tricortical iliac crest grafts are obtained, prepared, and tapped into the grooves with a Mohs impactor. An AO plate is screwed to the vertebra above and below the injured level to maintain fusion. The wound closed with layered sutures. A mastoidectomy is a surgical procedure that removes diseased mastoid air cells. The mastoid is the part of your skull located behind your ear. It's filled with air cells made of bone and looks like a honeycomb. The diseased cells are often the result of an ear infection that has spread into your skull. Transmastoid antrotomy, simple mastoidectomy. Through a postoral or endaural incision, the physician removes the mastoid cortex, outer bone, and drills out some of the mastoid air cells to enter the mastoid antrum. This is usually done as a drainage procedure for mastoid disease limited to the antrum region. A Mirignotomy with or without tube placement may be performed. A temporary drain may be placed and the incision is sutured. Mastoidectomy, complete. Through a postoral or endaural incision, the physician drills out the mastoid cavity. The mastoid sinus is exposed posteriorly. The tegmen, bony plate separating the mastoid and middle cranial fossa, is exposed superiorly. The posterior ear canal wall remains intact. The horizontal semicircular canal and part of the incus are visualized. Cholesteatoma or diseased mastoid mucosa is removed. The incision is sutured. A temporary drain may be placed. A dressing is applied. Mastoidectomy Radical. The physician makes incisions in the ear canal to develop a posterior tympanomeatal flap that is reflected forward. Through a post-oral or endoeural incision, the physician drills out the mastoid cells. The posterior and superior bony canal walls are taken down to the level of the facial nerve. The ossicles, except for the stapes if possible, are removed as well as the eustachian tube orifice mucosa, middle ear mucosa, granulations, and cholesteatoma. The middle ear and mastoid are exposed to the exterior ear through the ear canal. A large meatoplasty is performed. Packing is placed, the incision is sutured, and a dressing is applied. Mastoidectomy, modified radical. The physician makes incisions in the ear canal to develop a posterior tympanomeatal flap that is reflected forward. Through a post-oral or endoeural incision, the physician drills out the mastoid cortex. The mastoid antrum is identified. Granulations and any cholesteatoma are removed. The posterior bony canal wall is taken down to the level of the facial nerve. If cholesteatoma involves the ossicles, they are removed. The posterior skin flap and eardrum are repositioned to cover the facial ridge and part of the mastoid cavity. A meatoplasty is performed. The mastoid cavity and ear canal are packed, the incision sutured, and a dressing placed. Sympathectomy including radical mastoidectomy. Through a post-oral or endoeural incision, the physician drills out the mastoid cavity. The mastoid sinus is exposed posteriorly. The tegmen, bony plate separating the mastoid and middle cranial fossa, is exposed superiorly. The posterior ear canal wall remains intact. The horizontal semicircular canal and part of the incus are visualized. Various cell tracts around the semicircular canals are explored to drain the petrous apex. If this is unsuccessful, the posterior and superior bony canal walls are taken down to the level of the facial nerve. The ossicles, except for the stapes if possible, are removed as well as the eustachian tube orifice mucosa, middle ear mucosa, granulations, and cholesteatoma. Cell tracts between the carotid artery and cochlea or the jugular bulb and cochlea are followed to open the petrous apex and drain any infection. A meatoplasty is performed. A temporary drain may be placed. The incision is sutured and a dressing is applied. Mirignotomy including aspiration and / or eustachian tube inflation. Requiring general anesthesia. After the application of a local anesthetic or a general anesthetic and using a microscope for guidance, the physician makes an incision in the patient's tympanic membrane. Fluid is suctioned from the middle ear space and may be reserved for analysis. The eustachian tube may be inflated. No closure is required. Tympanostomy, requiring insertion of ventilating tube, local or topical anesthesia. General anesthesia. In a patient who has received a local or topical anesthetic or a general anesthetic, the physician inserts a ventilating tube. Under direct visualization with a microscope, the physician makes a small incision in the tympanum, eardrum. Any middle ear fluid is suctioned and may be reserved for analysis. The physician inserts a ventilating tube into the opening in the tympanum. No other treatment is required. Labyrinthotomy, with perfusion of vestibuloactive drug, transcanal. Do not report more than once per day. In a transcanal approach, the physician makes an incision in the posterior ear canal skin through the external ear opening and reflects the skin flap and posterior tympanic membrane forward. In either case, the posterior ear canal wall remains intact. The horizontal semicircular canal is visualized. Under microscopic guidance, a variety of procedures may be performed, including placement of a small, temporary or permanent tack through the stapes footplate, placement of a hook through the round window or ultrasonography or cryotherapy of the round window. The canal is packed.